We can start, sir.
Good evening, my dear friends, colleagues, students, and all. So, welcome to Yashoda Hospital Weekly Webinar Feast in association with the Society of Emergency Medicine and Anbai. So, every week we are coming with a newer emergency topic to update all our ER physicians and the students. So, as usual, this week we are with the hematological emergencies, which we common encountered in our day-to-day ER life. So, this week, I'll be in association with Dr. Ganesh Jaishetwar, who is a senior consultant hematologist, bone marrow transplant physician at Yashoda Hospital, Hitec City. Sir is associated with Yashoda Group since last 13 years. So he has independently and successfully accomplished more than 500 bone marrow transplants. So as we see, the common hematological emergencies in ED will be like a DIC, hyperviscosity syndrome, acute lung injury in the AML, hemolysis syndrome, superior vena cava syndrome, and hyperkalemia. So now I give the mic to Dr. Ganesh Jaishetwar to take forward. Ganesh sir, are you there?
Yes, sir. Good evening.
Good evening. Sir, the floor is open to you.
Yeah, thank you so much for your kind words and introduction. Good evening, everyone. At the outset, I must thank each of you for sparing time amidst your busy weekday, that too towards the weekend, for this important webinar from Yashoda Hospitals. So I'll just share my screen. I hope my screen is visible and I'm audible. Am I audible, sir?
You're audible.
And my screen is visible?
Yes, yes.
Perfect. So again, the topic of today's discussion is hematological emergencies and how together we can battle it better. So again, on behalf of Yashoda Group of Hospitals, I would like to thank each and every one of you, all the eminent clinicians from our region, for making a huge difference in the mankind by your dedicated work. So again, particularly this topic is hematological emergencies. So I had the privilege of working with very distinguished clinicians from the emergency department as well as critical care unit at Yashoda Hospital, Hitec City. So I owe a lot of credit and presentation expertise experience to them. So I bring warm greetings from Yashoda Hospital, Hitec City. It's a wonderful place which I had the privilege to work with. So when I was thinking of, when my team asked me to talk about hematological emergencies for clinicians, this is what I was, this was my situation. Kya karne aaya tha. I was not sure what to talk, which topics to cover. But again, when it comes to any clinical specialty, particularly hematology, it's a wonderful subspecialty of medicine, newest and the most happening subspecialty of medicine, where you really need to play the role of Sherlock Holmes, because diagnosis many a times comes with a lot of controversies, and that's where the impact and the role of teamwork, which we can solve out these puzzles and mysteries with a very rewarding outcomes. So my objective of my presentation today is, following this presentation, I'm sure for all patients presenting with various hematological emergencies, you will be able to describe appropriate clinical evaluation and monitoring approach, which will help you in implementing effective treatment. Again, the disclaimer here is, as I mentioned, it's a teamwork. Lot of these insights, those experiences gave me a lot of insights and valuable expertise. I owe a lot of these cases and case management tips to my distinguished teams belonging to emergency department as well as critical care department of Yashoda Hospital, Hitec City. So when it comes to hematology, again, it's a very fascinating specialty. And if you see, there are many, dedicated textbooks and book series on hematological, hemato-oncological emergencies. So, the beauty of hematology is it won't be an exaggeration if I say, to be an hematologist and to solve the hematological puzzles, it's just like solving the mathematical equations. So, once you know these algorithms, so I'm going to share throughout my presentation different algorithms to handle different emergencies pertaining to different hematological issues. So once the algorithmic approach is something which we are very fond of, and once you acquaint yourself with this kind of algorithmic approach, managing hematological issues, whether it is emergency, non-emergency, becomes a smooth task with very rewarding and gratifying outcomes. So in a way, artificial intelligence is taking up the medicine in a big way, all-time big way. So, not just the machine learning based artificial intelligence, we can acquire our own skills to work and act smart in cases presenting with emergencies in the arena of hematology. So when we think of hematology and emergency medicine or critical care, so it can be both vice versa. Hematology patients presenting in emergency or ICU, various cytopenias, and most serious of these cytopenias is neutropenic sepsis with or without shock. And these various sepsis leading to various organ failures like respiratory failure, multi-organ failure. And then hematological malignancies with very high count presenting with tumor lysis syndrome, and also hematological malignancies like Wiskott-Aldrich syndrome, multiple myeloma, presenting with life-threatening, organ-threatening hyperviscosity. And it can also be not just hematological patients, but normal non-hematological patients admitting in the emergency or ICU unit with hematological issues, like various spectrum of patients with various cytopenias like anemia, thrombocytopenia, DIC, coagulopathy, thrombotic microangiopathy, various degrees of anemia and various degrees of pancytopenia. So it's it's not just hematological issues presenting with critical care or emergency issues, but other specialty patients presenting with hematological issues, their management is also needs this team approach and needs this algorithmic approach, which can be very helpful in management. So this is brief, various organ specific manifestations of hematological emergencies. So it can be metabolic, various organ specific like neurologic, cardiovascular, infectious, and multi-organ specific. So essentially, when we think of hematological emergencies, it can be broadly categorized into 5 subcategories. Number 1, various cytopenias like low counts. It can be anemia, thrombocytopenia, neutropenia. Particularly, as I mentioned, febrile neutropenia is the most alarming and the most serious one when the patient has a absolute neutrophil count less than 500 with fever more than 100.4 degrees centigrade, or fever more than 100 degree Fahrenheit persisting beyond 1 hour. It can also be not just low counts, but also high counts like high WBC count. We call it as leukostasis or leukocytosis. Leukocytosis causing leukostasis, particularly with various CNS manifestations, and also leukocytosis presenting with tumor lysis syndrome. So these high turnover white cell counts also undergo either chemotherapy induced or spontaneous lysis, releasing various intracellular metabolites, causing various life-threatening manifestations, notably hyperkalemia, hyperphosphatemia, hyperuricemia, combined with hypocalcemia. And the fourth one is, the thrombotic, consumptive coagulopathy, DIC, and we monitor with various parameters. And DIC can be due to hematological issues, or DIC can present be due to vast spectrum of other specialty emergencies with hematological attention, like DIC happening in obstetric patients, DIC in postoperative patients, DIC in patients with underlying malignancy, DIC in patients with particularly old age patients. So I'm going to start with my first part, cytopenias. And when we think of cytopenias as a clinician, the most alarming, the most worrisome cytopenia to all of us clinicians is thrombocytopenia, right? And the thrombocytopenia, the etiologies can be varied. It can be simple infection associated, drug associated thrombocytopenia. It can be thrombotic microangiopathy like TTP, HUS associated thrombocytopenia, or it can be another deadly condition, DIC associated thrombocytopenia. Many a times, thrombocytopenia can be first presentation of various serious hematological disorders like blood cancers like leukemia, lymphoma, myeloma, or bone marrow failure syndromes like aplastic anemia, genetic disorders, immunodeficiency disorders. I just put three important differentials here. I'm sure all of us clinicians will agree. When a patient attends emergency department of any hospital with isolated thrombocytopenia, and you are just the patient gets admitted in the emergency and you get a call as a consultant, the patient will presenting with thrombocytopenia, how to approach. It can be simple thrombocytopenia like ITP associated thrombocytopenia. It can be serious thrombocytopenia with underlying conditions like TTP or DIC. So, the simple thing, the clinical presentation is different, the pathogenesis is different. And what is most important, many a times, that classical pentad, as described by Harrison's textbook of medicine, of TTP or thrombotic microangiopathy, is not commonly seen in clinical practice. Most of the time, these patients present with isolated thrombocytopenia, subtle mental changes which can be easily overlooked. But if the diagnosis of these life-threatening conditions is missed, and the gold standard treatment, for example, for TTP, plasma exchange is not started in earliest possible time, these patients can have very, very high mortality, right? And the same follows with DIC, the altered coagulation parameters, which are normal in other thrombocytopenia conditions, as well as the schistocytes are characteristic of TTP, and the raised LDH is again characteristic of thrombotic microangiopathy. So these simple lab tools, of course, the pathologist need to screen the peripheral smear to tell you about schistocytes, but the simple tool is very high LDH. Please be cautious in considering these thrombocytopenias as benign. Consider the serious thrombocytopenias like thrombocytopenia of TTP, thrombocytopenia of hematological etiologies like hematological malignancies, and be more attentive to these cases compared to the simple ITP or infection associated thrombocytopenia cases, which can be managed very easily. So like the famous saying, eyes are useless when the mind is blind. Unless and until we think of these differentials, we won't be able to save all these patients presenting in emergency with thrombocytopenia. The one important tool, as I mentioned, is LDH and coagulation parameters. It is prudent and it is helpful tool to order simple PT, APTT and LDH to all your patients. If LDH is high in thousands, consider serious etiologies. And if PT, APTT is deranged, consider coagulopathies like DIC. Again, TTP, the classical pentad, as I mentioned, hardly seen in less than 10% of patients. But what is most important is thrombocytopenia, altered sensorium, and evidence of micropathy. So the most important diagnostic criteria is thrombocytopenia, microangiopathic hemolytic anemia, and altered sensorium, with no explanation for these presentations. And that's fit into the criteria of TTP. You order Adam TS13, which takes at least 48 hours to get the reports, but you need to intervene fast. You need to start these patients on plasma exchange fast. So again, there are various, nowadays everyone has access to smartphone. personal smartphone. And nowadays, all these different algorithms and scores are just a few seconds away on your phone. So for, when in doubt, please revert to this course, the plasmic score, the gold standard for TTP diagnosis. There are 7 features: PT, platelets, lysis, active cancer, patient with history of transplant, the simple RBC parameter, MCV, INR, and creatinine. Based on the score, you just put the values on the scorecard. It will immediately within seconds flash you the score, and based on the score, this is what plasmic score on your smartphone looks like. And based on the score, you can decide, depending upon the plasmic score, whether the probability of thrombotic microangiopathy like TTP, HUS is high or low. And based on this, you can send Adam TS13, you can consider HUS also in the select cases, and you can act with therapeutic interventions based on your algorithm. Again, when we think of thrombotic microangiopathies, it is not always TTP. It can be hemolytic uremic syndrome also. The differentiating features I put it in this chart is, the patients presenting with thrombocytopenia and microangiopathic hemolytic anemia, evident by presence of high LDH, decreased haptoglobulin, and anemia, plus or minus cystocytes on the peripheral smear. If there, these patients should have various organ effects like neurological symptoms in the form of confusion, seizures, renal impairment in the form of elevated creat, abnormal blood pressure, abnormal urine analysis, and sometimes GI symptoms like bloody diarrhea, nausea, vomiting, abdominal pain, evidence of gastroenteritis. Again, based on the dominant feature, you can consider whether it fits into TTP or fits into HUS. If there is severe thrombocytopenia with very mildly deranged or almost normal renal function, and the response to plasma exchange is the gold standard for the diagnosis of TTP, that fits into TTP, continue plasma exchange, and at the same time add immunosuppressants based on your evaluation depending upon Adam TS antibodies as well as autoimmune profile. Whereas the patient has modest thrombocytopenia, more pronounced renal dysfunction, not so pronounced neuro dysfunction, and normal Adam TS, then you consider normal or low to normal Adam TS, then consider HUS. And here the problem is more intense because we don't have anti-complement therapy in India. So the management of this kind of thrombotic microangiopathy like HUS is a real challenge. Again, this applies to all the thrombocytopenias. I see a lot of clinicians, when the patient platelet count is 30,000, 40,000, 20,000, still they, order platelet transfusions with a fear that the patient will end up with internal life-threatening bleed, which is a myth. Remember, thrombocytopenia of any etiology, the mantra is treat the bleeding, not the platelet count. So, our threshold platelet count, target hemostatically safe platelet count is just 30,000. And for various procedures, dental procedures up to 30,000, minor surgery 50,000, major surgery 80,000, and CNS or eye surgery 1 lakh. So remember, barring these circumstances, high platelet count is not mandatory, and absolute platelet count for platelet transfusion, irrespective of etiology, is 10,000. I see nowadays there is a lot of dengue epidemic is going on, and a lot of patients with dengue fever, dengue hemorrhagic fever end up with thrombocytopenias with lot of platelet transfusions. So our practice should be evidence-based. So absolute indication of platelet transfusion in a patient with any, thrombocytopenia of any etiology is 10,000. In the presence of bleeding, 20, 30, 40, 50,000 is also acceptable. But barring this active bleeding or the patient intended for any intervention, we should not preemptively transfuse platelets in this kind of patients. Again, when it comes to thrombocytopenia, rather than indications of platelet transfusion, we should know the contraindications of platelet transfusion. So, for example, here the transfusions rather than beneficial may be detrimental. And these conditions are like thrombotic microangiopathies like TTP, HUS, antiphospholipid antibody syndrome, heparin-induced thrombocytopenia, where platelet transfusions can be counter, detrimental. DIC, unless and until patient has severe bleeding, severe ITP, irrespective of degree of ITP, platelet transfusions are not warranted unless and until these patients have severe ongoing or possible intracranial bleed, or these patients are planned for any invasive procedure. So barring these indications, platelet transfusion should be avoided in all these catastrophic conditions. So this is a spot, this is a polytrauma patient in emergency department. Can anybody, I'm sure a lot of you might have, diagnosed this case. This is a spotter. So you can see this is a polytrauma patient. There is a large abrasion, ecchymosis on the chest wall. There are possibly thoracotomy tubes, and you can see because of coagulopathy, there is continuous ooze at this tube insertion site, and the ooze is so severe that the underlying bed sheet is completely soaked with blood, and the patient's temperature is subnormal, 30.2 degrees centigrade. So this is, I'm sure all of you might have, understood. This is a polytrauma with DIC, and the thrombocytopenia here is because of DIC. So like just on a lighter note, like the famous Telugu cinema suspense Why Katappa Kill Bahubali, fetching highest revenues for Bahubali 2. Medicine is a wonderful science as well as a fascinating art. And as our teacher used to elaborate the famous punchline, the more why we ask ourselves, the more wise we become. So many a times the diagnosis is just itself is very much revealing, and we really need to be very negligent to miss the diagnosis. So when it comes to DIC, as a hematologist, this is, DIC for us is death is coming. It is so critical, it is so intense, and it is so life-threatening. So, in hematology circle, we call it as death is coming, and this is the algorithm for management of DIC. So DIC, remember, always is not bleeding type of DIC. Sometimes it can be thrombotic type of DIC. So, continuous supportive treatment, transfusions, and correction of coagulopathy. But if the DIC is many a times is occult or chronic DIC and asymptomatic, you just monitor lab parameters of DIC, and these asymptomatic chronic DIC patients will require low molecular weight heparin prophylaxis. And the patients with DIC with the bleeding profile, if they have a major bleeding or they are planned for invasive procedure, then only you should aim for platelet transfusion if the platelet is less than 50. Continue the FFPs, cryo transfusions if the PT APTT is more than 1.5 times normal. Give cryoprecipitates particularly which is rich source of fibrinogen if the fibrinogen level is less than 1.5 gram per deciliter. And as a rule for all DIC patients, tranexamic acid for hyperfibrinolysis only, otherwise it is contraindicated. Again, minor or no bleeding, continue LMWH prophylaxis and platelet transfusion only if the platelet is less than 20,000. Whereas if the patient has a thrombotic type of DIC, which can sometimes occur, bleeding type of DIC occurs mostly in obstetric DIC as well as postoperative DIC, whereas thrombotic DIC happens in patients with underlying cancer, patients of old age. These are the thrombotic type of DIC, patients with underlying uncontrolled autoimmune disorders. So here, LMWH prophylaxis for microthrombi, and if there are overt arterial events, antiplatelet drugs should be added. So I'll just in this context share a case from recently we saw. This is a 39-year lady presents with pancytopenia, generalized weakness, fever, short duration, 15 days, bleeding all over the body, skin, mouth, nose, and also heavy menorrhagia, short duration. And you can see the hemogram. There is hemoglobin is 7.3, WBC 1100, platelet 40,000. Now it is, just the clinical profile complemented with a simple hemogram can clinch the diagnosis in vast majority of the cases. Now, patient with such a severe bleeding profile and platelet count is 40,000. How commonly or how often you see a patient with 40,000 platelet count presenting with so profuse bleeding? So because of this, her disproportionate bleeding profile, clinical profile, we ordered coagulation parameters, and you can see PT, APTT sky high, fibrinogen is extremely low, and the pathologist sees the smear and calls us that there are some abnormal cells on the peripheral smear. So again, as I mentioned, clinical profile supplemented with the reading of hemogram, just like an ECG for a cardiologist, endoscopies for gastroenterologist, and imaging like CT, MRI for neurologist. The cell counter generated hemogram report is a vital tool to look into the patients presenting with hematological issues, and that can give us a very vital information about underlying etiologies. And by meaning the hemogram reading, I just don't relate to just numerical reading, but this histogram reading is also important. And this is a very simple tool. You just need to spare 4 or 5 hours of your time to understand the hemogram reading, and then you will master the art of reading hemograms, which will be helpful not just hematological issues evaluation, but evaluation of any specialty patients with abnormal hemograms. So again, bleeding disproportionate, this was explainable by coagulopathy. So this lady has DIC, overt DIC, and the pathologist called us that there are some abnormal cells on the peripheral smear called as promyelocytes, and this clinches the diagnosis as one of the most deadliest blood cancer on earth, called as AML-M3, acute promyelocytic leukemia. The treatment is very simple, supraphysiological doses of vitamin A and arsenic trioxide, and the cure rate is more than 95%, right? So the take-home message from this case: urgent hematology referral for emergencies associated with pancytopenia, like this case, when the pancytopenia patients have neutropenia with fever, neutrophil count less than 500 with fever, severe symptomatic anemia with hemoglobin less than 5, severe symptomatic thrombocytopenia with platelet count less than 10,000 or 20,000, any cytopenia associated with DIC, like this case, patients with cytopenia with abnormal peripheral smear, like there are blasts or schistocytes suggestive of thrombotic microangiopathy, patients with severe pancytopenia with clinical suspicion of aplastic anemia, patients with persistent, severe, prolonged pancytopenia with fever and splenomegaly, raising the possibility of HLH, and patients with pancytopenia or cytopenia with metabolic emergencies like symptomatic severe hypercalcemia, symptomatic hypocalcemia, hyperkalemia, hyperuricemia, raising the suspicion of tumor lysis syndrome, where the possibility of hematological underlying malignancies is very high, right? So this is very time bound here. Each and every hour is crucial. So teamwork is the key to, successfully get out of this crisis in patients presenting with cytopenia. So again, the case I highlighted, we didn't even do the bone marrow. We just did a simple genetic test, PML-RARA. Report came within 12 hours and we diagnosed this deadly blood cancer, APML. And before the diagnosis, we started this treatment on simple therapy for APML. So which are the circumstances in patients presenting with various cytopenias where you need to do a bone marrow? When there are abnormal cells called as blast, or the cancer cells in the blood, when there is leukoerythroblast picture, or when there is severe thrombocytopenia in extremes of ages like children less than 5 years, adults more than 60 years. So these are the circumstances where patients presenting with pancytopenia, you need to order early bone marrow studies, right? So like the famous saying, if you can't explain it simply, you don't understand it well enough. As I mentioned earlier, hematology is just a algorithmic approach, mathematical approach. Once you understand the nuts and bolts of managing, evaluating such patients, the evaluation and management becomes very, very rewarding and gratifying. Again, remember, many a times I see patients coming up with severe neutropenia. We lose many of them also because of severe neutropenic sepsis. Remember, the common obvious etiologies first. Many of you prescribe left and right various anti-epileptics, antithyroids, antiarrhythmics, antipsychotics, immunosuppressants, diuretics, antimicrobials, and NSAIDs. This can lead to something called as severe neutropenia. That terminology is called as agranulocytosis, and patients can actually die of severe neutropenic sepsis in drug-induced agranulocytosis. This should be kept in mind. And whenever you are prescribing these drugs, the CBC, at least once you start these drugs, once every 15 days to 1 month for a couple of months should be a routine practice. Again, India being a tropical hub, these infections are again common. So these are again common etiologies of cytopenias in our setting. Viral hemorrhagic fever like dengue, lepto, malaria, rickettsia can present with various cytopenias. So common obvious etiologies first is a mantra. So again, another subset where beyond thrombocytopenia, when patient presents to emergency department or in the casualty department in the odd hours with bleeding, are the patients who are on therapeutic anticoagulation who presents with active bleeding. How to manage them? So again, there are two major types of anticoagulants, vitamin K antagonists like warfarin acetrom, where you have to withhold the drug. If the patient has no active bleeding, just withhold the drug, give a dose of vitamin K. And if the patient has active bleeding, then you transfuse them with FFPs or prothrombin complex concentrate. Consider replacement of platelet when the platelet count is less than 50,000. Whereas for patients on newer oral anticoagulants like dabigatran, apixaban, rivaroxaban, here again, asymptomatic patients delay the dose, fluid replacements, depending upon the count, blood counts, transfusions, and they treat the bleeding causes like, if the patient had GI bleed, PPIs, and if the GI bleed is continuous, then probably gastroscopy. And if the patient has, active severe ongoing bleeding because there is no specific antidote, just like vitamin K antagonist, warfarin and acetrom, where vitamin K is an antagonist. For newer oral anticoagulants, there is no antagonist, so you have to just continue FFP, cryoprecipitates, or prothrombin complex concentrate transfusions in patients with ongoing severe bleeding. Whereas for minor bleed, you just need to hold the dose till the patient stabilizes, till the INR for vitamin K antagonist becomes less than 2, or for patients on newer oral anticoagulants till the minor bleeding stops, right? So again, another subset where bleeding is a concern is a patient with renal failure, a uremic patient presenting with bleeding. I'm sorry for this busy chart, but I will highlight here, the approach. And if the patient has, ongoing bleeding confirmed, suppose gastrointestinal or ongoing ecchymosis, hematuria, yes, then you assess whether the patient is hemodynamically stable or not. If the patient is hemodynamically stable, check whether the bleeding can be controlled with supportive care or surgery is needed. And if the patient's bleeding can be controlled, then give either FFP cryoprecipitates or 1 dose of desmoprocin. And if there is no, control of bleeding, then probably these patients will require surgical intervention. And if the patient is not hemodynamically stable, transfuse the patient depending upon whole blood or packed cells, DDAVP, cryoprecipitates, FFP, depending upon the intensity of bleeding. And if the bleeding doesn't stop, then the patients may require the conjugated estrogen as a measure to stop the bleeding in patients with uremic bleeding. And if the patient needs urgent surgery, then yes, DDAVP desmopressin, take the patient for dialysis and get the uremia under control, and then the patient can be taken for surgery. But if the patient surgery can be postponed, then this is the approach. But if the surgery is needed to be emergent, then we can give estrogen, transfusion support, and take the patient for surgical interventions. Now, changing gears further, the part 2 of my talk, severe anemia. So it's a common concern. We see a lot of patients presenting with various degrees of anemia. When should we order transfusion? So normal transfusion threshold across various specialties is when the hemoglobin is less than 7. Unless patient has chronic compensated stable anemia, this is the transfusion threshold, hemoglobin below 7. In an acute setting, this should be the indication for PRBC transfusion. Again, patients with hemoglobin of 7 to 8, if the patient has either high coronary risk and by virtue of their underlying coronary disease or cardiac issues, or patient with hemodynamic instability, like patients with hypotension, patients with hypoxia, patients with metabolic acidosis, patients with renal dysfunction, and patients with again high lactates because of sepsis or metabolic acidosis. Again, transfusion can be initiated even when the hemoglobin is between 7 to 8. Whereas patients with hemoglobin 8 to 10, only patients with acute coronary syndromes or patients with congenital heart disease, patients with active, various cardiac or cardiothoracic issues like, fresh mechanical circulatory device, thoracoabdominal aneurysm. So only the cardiac subset of patients need transfusion if the hemoglobin is between 8 to 10. Again, apart from that, in a patient with acute bleeding, so if the drain is more than 200 cc per hour, drain down the coagulation parameters like PTA, PTT, because if the transfusion requirement goes above more than 3 units, PRBC units within 1 hour, then you need to initiate the transfusion, massive transfusion protocol. Again, these are the various transfusion threshold, hemoglobin levels at which transfusion is mandatory. In ICU setting, in hemodynamically stable patient, hemoglobin up to 7 can be tolerated. So below 7, you should initiate transfusion. For orthopedic surgery, 8 grams, cardiac surgery, 7.5, GI bleeding, 7, and acute MI, 10 grams per deciliter. When we think of anemia, I would like to mention here the commonest intervention we use. Iron deficiency anemia is the commonest global health concern. You can see the third in common, chronic ailment. To be more precise, almost 1/3 of world's population is supposed to be iron deficient, various degrees of iron deficiency. And when we think of iron deficiency anemia, most of us are common, the common therapeutic intervention is oral iron tablets. But is it really effective? It comes with so much of GI toxicity. And once with various degrees of iron deficiency anemia is established, these patients need to continue iron supplements for at least 6 months and above. So nowadays, how long does it to take to treat IDA? So I will say treating iron deficiency anemia of various degrees with oral iron tablets is traveling from one place to another place in a blood cart. In the modern era, when we have these supersonic jets and all the in the era of jet planes, why do you need to travel long distance with the conventional cumbersome tools? So IV iron is the tool, so which gives a quick result. Natu movement, there are various generations of IV irons. Many of us are still practicing the old IV iron formulations like IV iron sucrose and so on and so forth, which are much toxic. So the newer formulations like carboxymaltose and isomaltoside, there are many advantages because of very minimal toxicity, ease of administration, cost effective, and because the severe life-threatening anaphylaxis is almost unknown. So this is the new way of treating iron deficiency. So this is how we calculate the iron dose for IV iron formulation. So to simplify, for patients with less than 70 kilo of weight, for mild anemia, 1 gram, moderate anemia 7 to 10, hemoglobin 7 to 10, 1.5 gram, and severe anemia 2 grams. Whereas for patients above the weight 70 kilos, for mild anemia with hemoglobin more than 10 grams, the need of IV iron dose is 1.5 grams, moderate anemia 7 to 10, hemoglobin 2 grams, and severe anemia with hemoglobin less than 7, 2.5 grams. So how do we administer IV iron? We can give bolus, but this is uncommon practice in our country because of the fear of various toxicities. But particularly isomaltoside can be given as a bolus, slow bolus of 500 mg in 10 ml over 5 minutes. So again, one of the common toxicity of IV iron is extravasation. And, this is the common, which is nowadays not acceptable to the patients, is extravasation, because it ends up with very nasty, discoloration of the skin, which lasts for long, right? So the most common practice we all revert to is IV infusion. And for IV iron infusion, the infusion has to be completed within 30 minutes. The lesser the infusion, the better is the tolerance and less is the toxicity. Particularly ferric isomaltoside, you can finish the infusion between 15 to 30 minutes up to 1 grams, whereas ferric carboxymaltose 30 minutes. So contrary to our common belief, the longer the infusion, less is the toxicity. This is wrong, because longer the IV iron infusion, more is the release of toxic free iron, labile iron release in the blood, and more of the reaction. So infusion should be completed within 30 minutes. That should be norm. Again, administration, with the 100 to 200 ml of ENS, and not more than once every week. Many of us have the practice of using IV iron sucrose once daily for 3 days in consecutive. But with the newer iron formulation like carboxymaltose and isomaltoside, we should space at least 1 week gap between 2 injections. If the dose is more than 1.5 grams, you should give it at a gap of 1.5 grams, at a gap of 1 week. Again, contrary to our belief that IV iron infusions are very toxic, life-threatening, nowadays with these newer IV iron formulations, the IV iron toxicity is very minimum. You should know the crux of IV iron administration. So the tolerance is excellent. The outcomes are very rewarding. So adverse event related to IV iron: hypersensitivity reaction, hypophosphatemia, transient hypertension, and transient nausea, flushing, and dizziness. Of which I would like to mention here the hyperphosphatemia, the hypophosphatemia. This particular complication is common with ferric carboxymaltose, where patient presents with weakness of the limbs, starting from few hours to up to 1 week post IV iron infusion. So we should be mindful of this complication. Supplementation of phosphates after doing the phosphate levels is the crux or key to manage this apparently dreadful complication from the patient's perspective. Again, you can see the treatment related adverse events compared to ferrous sulfate. You can see severe adverse events with ferric carboxymaltose and isomaltoside is almost zero. Life-threatening complications zero. Moderate 17%. So most of them are mild. And you can see again the comparative profile of isomaltoside versus carboxymaltoside. You can see the dose 1 gram up to 1 gram can be given in 50 minutes, whereas FCM has to given over 30 minutes, right? So again, FCM or isomaltoside, because these are newer, very refined IV iron formulations, the transferrin takes, after the drug is inserted into the circulation, more than 80% of the iron is taken by transferrin, while 20% remains stored in the reticuloendothelial system. So there is almost no risk of release of free toxic ionic iron, or which is called as non-transferrin bind iron or labile iron, which is the root cause of various life-threatening toxicities. So iron toxicity is because of NTBI or labile iron, which is very, very minimal because of the very robust structure of, so this ferric carboxymaltoside and isomaltoside, they have a robust carbohydrate shell, which is actually, the carbohydrate shell is made up of the carbohydrates which were used to treat anaphylaxis with previous IV iron formulations. So you can understand how safe it is and the anaphylaxis risk associated with these iron formulations. So we definitely need to change our approach to offer the best possible chance of anemia correction with IV iron formulation. And when it comes to iron toxicity, all of us should have awareness of the various toxicity, most notably hypersensitivity. And again, the commonest hypersensitivity with IV iron is the complement activation related pseudo allergy, CAPRA, which is common 30 to 40% patients, which is not life threatening. What you need to do in patients presenting with this complication, you need to just hold the transfusion for just 5 to 10 minutes, run the saline from the IV cannula, and once the toxicity or this complication is resolved, you can restart the IV iron, the medication. Whereas the type 1 Ig mediated hypersensitivity is rare. There are anecdotal cases. So again, these are the differences between various IV iron toxicity. I'll skip that. But most important and most scary to the patient is this called as fishbone reaction. This is a complement mediated reaction. So the commonest thing is flushing and most important truncal myalgia. And because of the truncal myalgia, patients are so scared to continue with the IV iron, the carboxymaltose or isomaltoside infusion. Most of the times clinicians end up throwing this IV iron formulation. Again, you have to understand that symptoms resolve spontaneously over a few minutes after pausing the infusion. Symptoms do not recur on rechallenge, and this is a mild hypersensitive reaction contrary to the belief or perception from the patients as life-threatening. So just an example, I'll share this. This is a fishbone reaction. Immediately after starting the IV iron infusion, this flushing, and what you need is just interrupt the infusion for 5 to 10 minutes, and this is the flushing completely resolves, truncal myalgia completely resolves, patient feels completely normal, and at which time you can continue the transfusion, right? So, these are the various algorithms of management of IV iron associated hypersensitivity nowadays with the newer formulations like isomaltoside and carboxymaltoside. These reactions are rare, but anyone who is practicing IV iron infusion in their day-to-day practice, this chart should be ready, hanging on the walls in the injection room. The management becomes easy. So I will skip this. This is the complex part, but what is most important to understand is the severe life-threatening reactions are rare, simple complement-mediated reactions which resolve on its own within few minutes of IV iron interruption are the commonest toxicities. So again, these are various algorithms. I'll skip that. Most of the reactions are mild to moderate, which resolves only on interruption of IV iron formulation. So now again, I will share one WhatsApp message from one of the patients from Northeast. This patient went back home on day 3, day 4, developed flushing and weakness of the limbs. She could not, move her body because of extreme, weakness of the limbs because of hypophosphatemia. And, just on the WhatsApp communication, I suggested them to do the phosphate levels and supplement phosphates, and you can see the patient recovered within few hours. So, this was about IV iron. So another common problem in emergency department is massive transfusion protocol. When when you end up transfusing more than PRBC units within 1 hour, ordering more than PRBC transfusions within 1 hour because of ongoing or extensive bleeding, when there is the shock index is more than 1, when the heart rate divided by systolic BP, this ratio is more than 1, the ABC score, like the systolic BP less than 90, heart rate more than 120, and the penetrating injuries, and the RABT score like shock index more than 1, pelvic fractures, and positive fast ultrasound. So these are the tips, simple facts of massive transfusion protocol. Trigger massive transfusion protocol, prepare the team, continue giving tranexamic acid. This is a very helpful supportive tool. Continue tranexamic acid 2 grams every 4 to 8 hourly, which will try to stop the bleeding. Continue testing the coagulation as well as CBC parameters and the lactates and electrolytes through VBG every hourly. The target is to keep the transfusion target is to give 2:1 PRBC versus plasma. So for each 2 PRBCs, 1 FFP unit. Temperature management, and once the requisite the hemoglobin more than 8, coagulation parameters like PT APTT less than 1.5, this target trigger is achieved, you can stop the transfusion protocol. So again, this is a this kind of ready-made algorithms are readily available in the most emergency departments. When to activate massive transfusion protocol, how to monitor every 30 to 60 minutes, and when to stop. So even though the thromboelastograph is not readily available in most of the emergency departments, but it can be a vital, crucial tool of monitoring transfusion. So part 3 of my talk is again the third cytopenia, that is neutropenia, where the care has to be urgent because these patients can have very high rapid fatality if you don't attend them emergently. From hematological perspective, hematopoietic stem cell transplant as well as blood cancer like AML associated neutropenia is very important. The patient with neutrophil count less than 500 with fever, it's at literally this is a what you call it as a time bomb. If you don't act fast, the mortality can be very, very high. Again, neutropenic sepsis in emergency rooms, almost 10% patients in hematological spectrum. If you don't attend them, within time, the mortality associated with this neutropenic septic shock can be as high as 50%. So the mortality, there are various mortality indicators. So essentially, any patient with any fever, with neutropenia, with or without shock, with end organ failure like respiratory failure, multi-organ failure, the mortality is high. You should start them on immediate antibiotics, broad spectrum antibiotics after ensuring hemodynamic stability. And these are the common bugs underlying neutropenic sepsis. Most common one are bacteria, the neutropenic sepsis due to bacteremia, 70 to 90% patients. And second commonest is the mycosis or fungal infections, 5 to 10%. Again, these are the various charts based on the patient's hemodynamic stability and the degree of neutropenia. You should try to administer broad spectrum antibiotics within 1 hour admission in the ICU. The first line antibiotic is either beta-lactam monotherapy, piptaz, or carbapenems. And if the patient has severe sepsis with shock, you should add either targocid, vancomycin to cover the gram-positive sepsis. And in a patient who has multiple previous hospitalizations where the carbapenem-resistant gram-negative sepsis probability is high, addition of polymyxin, colistin, or ceftazidime, avibactam based on patient's hemodynamic stability is important. Now, switching gears further, the transfusion reactions. These are the common transfusion reactions: fever, either because of febrile non-hemolytic transfusion reactions, acute hemolytic transfusion reactions, allergic reactions like anaphylaxis or urticaria, and the hypotension because of various release of bradykinins in the blood products, cytopenias, hemolysis, mostly hemolytic transfusion reactions, infections. And the most notable and most serious one is that after transfusion patient developing respiratory distress. This can be either due to transfusion related lung injury or transfusion associated circulatory overload, which have high mortality. So I'm sorry for this busy chart, but you can see the common and notable reactions are either febrile or non-febrile hemolytic transfusion reactions, which happens within within hour to 4 hours, where stopping the transfusion, giving the medications like antipyretics and fluid balance, checking the hemodynamic stability is important. For allergic transfusion reaction, stop the transfusion and give H2 blockers plus or minus steroids. Whereas other serious life-threatening complications like TRALI or TACO, transfusion-related acute lung injury, which can happen within 4 to 6 hours of transfusion, and this is most serious of transfusion reactions, where it can also lead to mortality. The mortality rate in TRALI is about 15%. The treatment is rapid, assessment, ventilatory support may be required if the patient continues with progressive respiratory distress, and mostly happens with various blood products, common with platelet transfusion because of higher leukocyte content. Now, second serious complication is transfusion associated cardiac overload, again, which happens within 6 hours of transfusion. This is because of volume overload, rapid succession, blood units transfused in rapid succession, leading to volume overload, particularly in patients with various cardiac comorbidities, patient present with progressive breathlessness. Here, again, you can minimize the number of transfusions, use liberal diuretics, and if at all transfusion are needed, volume reduced units. Again, various electrolyte abnormalities like hypocalcemia, hyperkalemia, hypothermia, this needs attention and monitoring and whenever needed, hypocalcemia, 1 gram calcium every 4 hourly till the patient's calcium levels revert to normal. The part 4 of my talk is hematological malignancies presenting with various, emergency, hematological emergencies. The most common is acute leukemia presenting with leukocytosis and leukocytosis associated complications. So again, the differentiation between acute and chronic leukemias, in brief, acute leukemias blast or cancer cells in the blood, whereas chronic leukemias very high number of normal looking neutrophils or lymphocytes in the blood. So acute is intense, chronic is recurring. When it comes to hematological malignancies, I like to emphasize here that we have made a notable development in the hematological malignancies management. Just a example, ALL outcomes you can see over last 50 years. 70s, the cure rate was less than 10%. Today, the cure rate is more than 90-95%. When it comes to blood cancer or cancer therapy, we cannot forget our own Telugu superhero, Professor Yallapagrada Subbarao, Miracle Man of Medicine, resident of Bhimavaram, and you can see enormous, credentials to his, illustrious career. He was the first one to synthesize folic acid and the first one to synthesize first anti-cancer drug, methotrexate. So, unfortunately, despite his notable contributions, the most deserving man for Nobel felicitation was not felicitated. In fact, all the three people worked with him were felicitated with Nobel, but his wonderful journey can be come across this wonderful book, Wizard of Wonder Drugs. So again, tumor lysis syndrome, very life-threatening complication, hyperuricemia, renal failure, dyselectrolytemia can be life-threatening. Again, hyperkalemia, ECG changes, arrhythmias, paresthesias, myalgias, hyperphosphatemia, again leading to secondary hypocalcemia, leading to renal failure, seizures, and cardiac arrhythmias. Renal failure because of either hyperuricemia or nephrocalcinosis, or due to obstructive nephropathy. So all these life-threatening complications, the management is simple: aggressive IV hyperhydration, allopurinol or febuxostat for blocking this xanthine oxidase, and patients with very high uric acid levels above 11, above 7 or 8, you can use this novel drug rasburicase, which can completely make this uric acid, which has low solubility, to convert into allantoin, which has high solubility, which gets excreted by urine. So management, again, in nutshell, IV hyperhydration, allopurinol, depending upon the uric acid level, rasburicase, and symptomatic management of dyselectrolytemias. So again, these hematological malignancies with these dreadful complications are no more life-threatening as it used to be once upon a time. Again, what is new in the field of hemato-oncology? We are in the era of precision hemato-oncology. Novel immunotherapies and novel targeted therapies are available to our disposal with its own unique complications which can come to emergency wards. Another common complication coming to ER is hyperviscosity. This can present with either mucosal hemorrhage, visual or neurological disturbances. Common etiologies are either multiple myeloma, Waldenstrom's hyperglobulinemia, or myeloproliferative disorders like polycythemia, myelofibrosis, essential thrombocythemia. Sometimes sickle cell disease disease patients also can present with hyperviscosity. Management is simple, depending upon the underlying etiology. The plasma exchange, cytoreductive therapy, phlebotomy for polycythemia, for essential thrombocythemia and polycythemia, the chemotherapy like hydroxyurea, antiplatelet drugs, aspirin are useful. Whereas for sickle cell disease, RBC exchange transfusion can be useful. So the another complication associated with hematological malignancies is spinal cord compression. Again, depending upon the patient's neurological symptoms, the patient has neurological symptoms, you start them on steroids. And if the patients are assessed for spinal stability, the patient has a unstable spine, you can take them for decompressive surgery or spinal stabilization. Whereas patients with stable spine, you can give them radiotherapy to manage the spinal cord compression. Whereas patient without neurological symptoms, chemo or radiotherapy enough, no surgical intervention required. The part 5 of my presentation is switching gears further, sickle cell crisis, a common presentation in our Telangana region. So again, remember the mantra of sickle cell crisis is aggressive hydration, careful attention to oxygenation, supplemental oxygenation, prompt and adequate analgesia, prompt treatment of infections with antibiotics. So hydration, oxygenation, adequate pain control and antibiotics is the mantra. So if the patients, the aim is to keep saturation more than 95%. If a patient has a saturation less than 95%, you can supplement them with high flow oxygens. Again, patients with, red flags like chest pain, saturation less than 95%, increased oxygen requirement, persistent fever, and persistent respiratory distress. These are the patients you need to shift them to ICU. So again, going through all these hematological malignancies, of course, there are many challenges, but there are many breakthroughs, many new drug approvals. And there is a lot of hope and cure across this vast hematological spectrum, patients presenting in emergencies, as well as other specialty patients present with hematological issues. So future of medicine is very bright. The teamwork is the key for managing all these life-threatening complications in patients with hematological issues or other specialty issues. So I will stop here. I know I had overshooted my time by 5 minutes or so. So thank you so much for your attention, and I'll be happy to answer if there are any questions on this August virtual dash. Thank you so much, one and all.
We
Sir, your voice.
Sir.
Yes, sir.
No.
So should I start with the chat box, sir? So I will start with the questions on the chat blocks as well as Q&A. So in the Q&A session, there is a question: if we are planning for central venous line to be placed in ER, and if the patient has thrombocytopenia or DIC or any anticoagulant like warfarin, what should be done, sir? So yes, this is a very common question in patients presenting in the emergency. If the patient is needed to be placed with central line, the platelet count of 20 to 30,000 is enough. But if the patient is already on anticoagulants like warfarin or newer anticoagulants, then probably you need to stop anticoagulation for, and you also need to order FFPs and cryoprecipitates to ensure adequate hemostasis before putting them on central line. So because most of the times in the ER we put jugular double lumen catheters, any arterial poke or multiple pricks here can be life-threatening because the bleeding can be uncontrolled. So it is always better to order or do these interventions under coagulation factor replacement. So second question is prothrombin complex concentrate available? Absolutely, yes. It's a commercially available prothrombin complex concentrate by multiple pharma companies, and depending upon the indication, the dose varies. So it is readily available, and it is easily doable in our emergency or critical care setting. Sickle cell anemia with veno-occlusive crisis, when to choose NSAIDs versus opioids? So again, asked by Dr. Mansoor Ali Khan, sir. So again, a very important question. Sickle cell anemia patients have, NSAIDs should be avoided as much as possible because of various, complications associated with NSAIDs. But if the pain is not controlled with opioids alone and pain intensity is severe, then as an add-on therapy, you can add NSAIDs. But the first preference is opioids. And if the pain is not controllable with opioids plus paracetamol combination, particularly with severe back pain and acute chest syndrome, you can use NSAIDs. So again, I will, chat box, I had answered all the questions on Q&A session. So in the chat box, again, use of GM-CSF and L-Trombopag in leukopenia and thrombocytopenia, respectively. Gururaj Kulkarni sir, a very nice, important question. So yes, GCSF for patients presenting with febrile neutropenia is absolutely recommended, whereas L-Trombopag or romiplostim in patients presenting with thrombocytopenia, the time to platelet recovery with these agents L-Trombopag and romiplostim is 1 to 2 weeks. So depending upon the possible underlying etiology, you should use platelet transfusions judiciously. But yes, as a therapy to recover platelets sustainably, these drugs can be used in the various settings. Dr. Somappa sir, ferric carboxymaltoside infusion causing hypophosphatemia and risk of sudden cardiac death. Please clarify. Yes, particularly of two novel IV iron formulations, ferric isomaltoside and carboxymaltoside, the incidence of hypophosphatemia is higher with FCM, carboxymaltoside. Risk of sudden cardiac death is there, of course, but the incidence is very, very low, less than 0.5%. But yes, ideally, all patients receiving IV iron, their phosphate should be monitored or checked before giving IV iron. And if patient has, before IV iron infusion, hypophosphatemia, it should be corrected before IV iron infusion. That is not a common practice in our setting, but if the patient presents with these various, symptoms related to hypophosphatemia, the phosphate level should be checked and the phosphate correction should be prompt. The incidence of sudden cardiac death is there theoretically, but the incidence is very, very low. Second is who are, Dr. Somappa sir again, who are at risk of hypophosphatemia. The subset of patients who are at risk of hypophosphatemia are patients of old age, above the age of 60 years, pregnant women, patients with cardiac ailments, and patients with comorbidities like diabetes. These are the patients who are at very high risk of hypophosphatemia. So here in this subset of patients, phosphate level should be checked before starting IV iron infusion. So I hope this answers the questions of Dr. Somappa sir. The next question is, Dr. Pushpa madam, can we give FCM in thalassemia pregnant patients? Very important question. Any IV iron infusion should be avoided in first trimester pregnancy because of possibility of inducing abortion. So IV iron is safe only during second and third trimester. So yes, FCM can be given I'm sure the question madam wanted to ask is thalassemia minor pregnant patients, because thalassemia major patients have iron overload and adding iron infusions can be detrimental. But thalassemia carrier patients with documented iron deficiency, IV iron infusions like ferric carboxymaltoside and ferric isomaltoside can be given during second and third trimester pregnancy. Next point madam asked was 1 unit PRBC should be completed in how many hours? Very important and crucial day-to-day use question. So once the packed red blood cells are issued from the blood bank, the transfusion should be completed within 4 hours, if not 4 hours, but within at least at the max 6 hours, because the more the blood unit is kept in the room temperature, more is the possibility or threat of bacterial contamination. So the transfusion with packed red cells should be completed within 4 hours. Transfusion with platelet should be completed within 30 minutes. Transfusion with freshly the FFPs and cryoprecipitate should be completed as early as possible. Particularly platelet transfusion should be completed as early as possible, because normally platelets are stored in the platelet agitator, and once they are off the platelet agitator, the chances of bacterial contamination is very high. So platelet transfusion should be completed within as much early time possible, at least within 10 to 30 minutes, whereas PRBC should be completed within 4 hours. Madam also asked, should we give routinely Lasix Avil before transfusion? Yes. So this is a very important question. So we don't give pre-transfusion, pre-medications for all transfusions. Yes. If patients requiring more than 1 unit PRBC transfusion, the Lasix should be given 10 to 20 milligram after each unit. Patients requiring multiple FFP transfusions. Normally, we give 15 ml per kilogram of FFPs in patients with active coagulopathy. So we use 20 milligram Lasix after each 2 FFP units. How much time should we keep between, how much time we should keep the patient after blood transfusion in hospital? Ideally 2 to 4 hours, because the maximum dreadful complication occurs within first 6 hours like trally or taco. So we should monitor these patients for at least 2 to 4 hours post transfusion in the hospital setting. Thank you so much, madam. So next question is from Dr. Gopi Chand Varadkar, sir. Any role of CSF examination in patients with altered sensorium in leukemia? Very nice question. Absolutely. Patients presenting with altered sensorium with a newly diagnosed leukemia, the commonest cause of altered sensorium is leukostasis, cerebral leukostasis than the CNS leukemia. So here first you have to ensure that the coagulopathy is ruled out by doing PT-APTT, and platelet count should be above 50,000 before doing CSF. So if a patient with newly diagnosed hematological malignancies like leukemia with altered sensorium, platelet more than 50,000, PT-APTT less than 1.5 times normal, and fundoscopy ruling out papilloedema. If all these parameters are met, then you can do CSF analysis by lumbar puncture. Very good question. Thank you so much, Gopi Chand, sir. Dr. Pushpa Madam, again, in pregnant patients, level of platelet count that need evaluation. Again, a very important, pertinent question. It all depends on the which trimester of pregnancy, what level of platelet, and other blood count abnormalities. If the thrombocytopenia is the isolated finding in first trimester, any platelet count you need to evaluate. Most of the time, the first trimester pregnancy, the commonest thrombocytopenia cause is ITP, whereas second and third trimester pregnancy, platelet count above 70,000, the commonest cause is gestational thrombocytopenia, which needs watchful waiting and periodic monitoring. But any pregnant lady with platelet count less than 50,000 need thorough evaluation to pinpoint the underlying etiology. Most notably, pregnant lady in the third trimester pregnancy with hypertension and any thrombocytopenia needs very aggressive prompt evaluation to rule out hypertensive disorders of pregnancy like preeclampsia, eclampsia, HELP syndrome, acute fatty liver of pregnancy, which needs prompt termination of pregnancy. So I hope this answers madam's question in brief. So next is Dr. Prashant Patil, very informative talk. Thank you so much, sir. Then again, Mansur Ali Khan, sir, appreciating our talk.
Then whole blood transfusion versus SDP versus FFP in dengue hemorrhagic syndrome, sir.
Yes, Dr. Nagarjuna Kamani.
Nagarjuna
So
Kamani.
thank you so much for this question, sir. Again, the idea of whole blood transfusion in dengue hemorrhagic syndrome as a replacement of all three components of blood, PRBC, FFP, and platelets, coagulation factors and platelets. This is a concept, I think across all the transfusion indications, dengue shock syndrome is the only indication where you can give whole blood, and the whole blood should be collected within 24 hours. The whole blood which is lying in the blood bank more than 24 hours doesn't solve its purpose, because the platelets are not functional, coagulation factors are also non-functional. So most important requisite for whole blood transfusion in dengue shock syndrome is the whole blood should be transfused within 12-24 hours of collection. That is very important. So whole blood transfusion versus SDP versus FFP, of course, the ideal setting, in the secondary and tertiary care hospital setups, each component should be transfused depending upon the requirement. Patients with platelet count less than 10,000 or patients with platelet count less than 20,000 with active bleeding or fever, platelet should be transfused, SDP should be transfused. Patients with active coagulopathy or dengue shock syndrome with altered PT-APTT, FFP should be transfused, and patients with dengue shock syndrome with hemoglobin less than 7, the PRBC should be transfused. So ideally, separate blood components should be transfused depending upon the underlying abnormality. But in the primary care setting, if the component facility is not available, whole blood as a replacement of all the 3 blood components can be transfused, but it should be transfused within 12 to 24 hours of collection. Beyond 24 hours, it doesn't hold any value. I hope that answers Nagarjuna sir's question.
And how long will it take to improve HB after 1 dose of iron transfusion, sir?
Very important question. Thank you so much, Khaja Hussain sir. So whether you give IV iron or oral iron, the time to recover or time to normalize hemoglobin is 2 months. The hemoglobin recovery doesn't change with oral or IV iron. But most important advantage of IV iron is you can calculate the deficit and you can give the entire deficit in the form of IV iron infusion in 1 or 2 infusions. Whereas for oral iron supplementation, you have to continue for hemoglobin correction 3 months and then to replenish the iron stores in the body another 3 months. So for oral iron, once started, should be continued for at least 6 months, whereas IV iron can be given in 1 or 2 shots, complete deficit can be corrected. But recovery time of hemoglobin is normal 2 months. This is because of simple physiology. The normal RBC lifespan is 120 days. The half-life is 60 days. So RBCs incorporate iron at different particular stages of development, like late normoblast and orthochromatic normoblast. These are the RBC stages where iron gets incorporated into the cytoplasm. So no matter you load the entire iron with, in IV iron formulation in 1 go, the recovery time of hemoglobin is 2 months only.
So is there any role of papaya leaf in thrombocytopenia?
Again, a very important, pertinent, excellent question. Thank you so much, Vasishtha Gaikwad sir. Papaya leaf is absolutely non-scientific. The only person benefiting out of papaya leaf extract is the companies which are manufacturing papaya leaf extracts. It has no scientific value and it doesn't scientifically carry any rationale in patients with thrombocytopenia for platelet recovery. So it is completely non-scientific, non-rationate. We should refrain from such, such kind of non-scientific practice.
The next question is, can I give tranexamic acid to a patient prior to FFP with active bleeding in gums who has MBR on acetrom daily?
Absolutely. Fantastic question, sir, Rubiga madam. So yes, tranexamic acid works by, it is an antifibrinolytic agent. It doesn't lead to activation of coagulation on its own. So any patient presenting with mucosal or cutaneous bleed, tranexamic acid can be safely given in an active bleeding patient, irrespective of their underlying etiology, like Madam mentioned MVR on therapeutic anticoagulation with acetrom. So tranexamic acid can be safely given in this subset of patients because it doesn't precipitate clotting on its own. It just works as prevention of dislodgement of clot from the mucosal surfaces.
The next one is, Press syndrome needs anti-hyperviscosity drugs in peripartum ladies.
So absolutely another important question, Deepak Gore sir. So Press syndrome most of the times is because of either hypertension, uncontrolled hypertension, or due to the obstetric complications or due to drugs. These patients don't need per se hyperviscosity drugs. The treatment of underlying etiology is important in this subset of patients. We don't need anti-hyperviscosity drugs in peripartum patients presenting with breast syndrome. We definitely need anti-hypertensive drugs, and correction of underlying etiology is important, whether it is drug-induced PRASE or it is hypertensive disorder associated PRASE like eclampsia, preeclampsia, HELP syndrome. So correction of underlying cause is important in this subset of patients.
What is the level of HB for PRBC transfusion for chemo-induced anemia?
Another important question. So there is a heterogeneous practice about the transfusion threshold with regard to hemoglobin. As I mentioned, hemoglobin of 7 is the universal hemoglobin threshold for PRBC transfusion. But yes, patients with hemodynamic instability, patient with hypoxia, metabolic acidosis, patient with cardiac comorbidities, hemoglobin of 7, 8, or sometimes 8 to 10 in patients with severe cardiac comorbidities also is a threshold for PRBC transfusion. But the common simple answer is hemoglobin of 7 is the threshold for PRBC transfusion in any patient, including patients with chemotherapies.
One more question is, I wanted to know cancer patients with immunosuppressive medication presenting with pancytopenia with dengue shock syndrome, how to approach with transfusion of components.
Yes, so cancer patients on immunosuppressive chemotherapy medications presenting with
Pancytopenia.
and pancytopenia. So again, dengue shock is a life-threatening complication irrespective of associated comorbidities. Dengue shock itself has a very high mortality, morbidity risk, and the management of dengue shock, is all supportive. Fluid replacement, coagulation correction, transfusion support as per the underlying, deficits. Platelet should be kept above 30,000 in dengue shock. The PT-APT should be maintained between less than 1.5 times normal. And most important, the end organ perfusion should be maintained with various transfusions. So whether the patient, of course, the patient with active cancer on ongoing chemotherapy, they are more prone to more dengue shock associated complications. So the management remains supportive, and depending upon the coagulation factor deficits as well as blood deficit, management is directed to correct the hematological abnormality.
One more question is, after one dose of iron, is it advisable to continue oral iron?
Again, a very important and fantastic question. If your iron deficit is more than 1 or 1.5 grams and you end up giving only 1 gram of IV iron, then probably you can continue oral iron. But if the patient has mild anemia like hemoglobin more than 10, the deficit is hardly 500 to 1 gram. When you give 1 gram of IV iron, you don't need to continue the toxic oral iron.
Sir, last 3 questions, sir. Dose, there is any cutoff criteria for PRB transfusion for chemo-induced anemia?
Yes, the hemoglobin of 7 is the universal standard, but some people keep the hemoglobin above 8 with PRBC transfusions.
Sir, can I give tranexamic acid to a patient prior to FFP with active bleeding post MVR on anticoagulant?
Sir, can you come up again with the...
Sir, can I give tranexamic acid to a patient prior to FFP?
Yes, absolutely. So as I mentioned you earlier, tranexamic acid is an antifibrinolytic agent, can be used under various, actively bleeding patients, particularly the mucosal bleeding patients, gut and oropharyngeal bleed, because it doesn't precipitate coagulation on its own.
Last question, sir. Use of GM-CSF and electromobagag in LP and TCP respectively.
So I think this is the GMCSF for leukopenia or neutropenia and L-thrombopag in thrombocytopenia. Of course, patients presenting with neutropenia, if the underlying cause is known, like drugs or underlying hematological malignancies on chemotherapy, you can use GCSF. But if the cause is not known, unless and until you work up with necessary investigations like bone marrow studies, the GCSF should be avoided because it can completely alter the bone marrow picture. Of course, L-thrombopag and romiplastim can be used in thrombocytopenia, just that their duration, the onset of action is 1 to 2 weeks. In acute care setting, platelet transfusion is the way. But yes, if you want to sustain the platelets because of various known underlying etiologies, you can use this just like GCSF or erythropoietin for anemia and leukopenia.
Thank you, sir. That was an elaborative session. So it was almost a 1.5 hour session with 127 participants.
Fantastic.
And thank you for your patient answering, sir. So we have learned many things from this webinar. It's having a great rapport with you, sir.
Thank you so much, sir. And thank you one and all for joining this, even though we would have loved to have a in-person physical meeting, but even though on virtual dais, sparing your time amidst busy work schedule, and I'm indebted to your relentless support over last many years, many decades at Hyderabad, and really look forward to many such academic interactions. Thank you one and all. Take care, stay safe. Thank you.
Yeah, thank you, everyone. Thank you, Yashoda Hospital SEMI, for having this wonderful weekly webinar, which is enlightening all the students, all the faculties, enriching their knowledges.
Thank you, sir. Take care.
Thank you. Good night. We see you next week.
Thank you, sir.